So I'll just do a quick third-degree heart blood bradycardic case. And I've already done today quick by 2 minutes late.
Oh boy.
The latest news
Yeah, you have everything done?
It's a brief value. So just finish this now. We're good.
All right, welcome everybody to the first Journal Club of the year. It's a new year. We're pretty excited. Even more IT and technology surprises coming up this year. For those who don't know, we started every single year with the same Journal Club article to keep things simplistic, which is Scott Weingart's article. If you're listening, please let us know about pre-oxygenation. Because everybody always asks me, if I only can read one article in medicine to get smart, what article do I read? And I usually tell them this article, right? So I keep it simple. So it's a Weingart-Levitan pre-oxygenation prevention of desaturation during emergency airway management. It's a timely article, even though it's from 2012. Still, most people don't pay attention to this stuff, and they're still outdated. So every year that goes by, and it's 2018 now, I can say you're only 6 years behind this great article. So this just tells you you need to keep up with your practice. We start out, for those who are new to us, we start the same way every single journal club by asking people to do interesting cases. Then we go through our articles. Usually we have anywhere from 2 to 10 articles. And then the fellows all rotate, our new group of fellows will rotate from doing an article every single week. And then we shut off the camera and we do some operations. This week, like most weeks this summer, we're actually in Wall Township, New Jersey, at Monarch, Maine. And then starting in a month or so, we'll go back to rotating between North and South Jersey, or we can come to a location near you, as we've gone on the road a few times to see other people's systems and what they have to offer. So if you send us a question, we'll do a shout out to wherever you are, anywhere in the country. I apologize for being a couple minutes late this week. We'll make a bigger effort to start promptly at 1 o'clock. So, and I'm also supposed to tell you to like us on Facebook, right? Is that what I tell them?
Yes.
to like us on Facebook, whatever that means, and then people will know we're on. But we're always Wednesdays at 1 o'clock, and we'll give you a heads up if we're not going to do a journal club. And next Wednesday we'll be back in the same exact location. And for those who don't know, we instead of having our statistician far away in Alabama, he's with us now in New Jersey, AJ. So although we're not doing, of course we bring him here and we don't do any odds ratios or statistics, but nonetheless we start out with airway. So just interesting cases. So we try and discuss the latest, greatest stuff, and I'll just tell you my somewhat interesting case, although we've talked about this ad nauseum now. People still are not doing it well. We get calls all the time for people on the console who are in third-degree heart block, bradycardic, and hypotensive. And invariably, the one thing besides doing transvenous pacing in the ER, transvenous prehospitally, or giving some atropine or something, we are big believers in giving prophylactic calcium chloride to these patients, because we know hyperkalemic causes bradycardia. So we're big believers. Somebody calls me on the radio and tells me this patient has new onset bradycardia. We throw calcium chloride at them automatically. We throw 1,000 milligrams. Calcium chloride is 10%. So if you ever heard me speak, my cheat formula for a percentage, which works for everything in medicine, like 4% cocaine, 1% lidocaine, you cross off the percentage, add a 0, and that's milligrams per milliliter. And that works for everything in medicine. So 10% calcium chloride, cross off the percentage, add a 0, is 100 milligrams per ml. 4% cocaine is 40 milligrams, cross off the percentage, 40 milligrams per ml. It works for everything in medicine. So 100 milligrams per ml for calcium chloride is basically 10 mLs, which is 1,000 milligrams in the average adult. If you're right, you'll save the person's life. And if you're wrong, you're not going to hurt anybody. So if they're not hyperkalemic, who cares? But in the pre-hospital setting, it's not worth it to wait, because we know hyperkalemia causes bradycardia. It's well established. And I will acknowledge that I've made the mistake, and seen many other people make the mistake, in putting in transvenous pacers in these patients only to have potassium come back like at 8 acutely, and subsequently I felt like an idiot when I gave like 2,000 of calcium chloride, and the patient's bradycardia is resolved, and they didn't need a Cordis or a transvenous pacer to start with, right? So I acknowledge I made the mistake. It's not a nice, simple thing to do. That's it for my quick speech. Who's got an interesting case this week?
So I have a emergency department case, but can be translated. Figured it would be interesting to talk about. It was actually, you mentioned it briefly in the Medical Mondays email that you had sent out about what does unstable mean when you have a tachydysrhythmia, and chest pain or shortness of breath. Everyone wants to jump to calling that an unstable tachydysrhythmia. But I had a patient in the ED, younger autistic patient. When I say younger, still an adult, but younger autistic patient. Big, heavy, round face, not the greatest airway that you want to administer, but nonetheless, volume depleted from a GI illness, came in AFib, RVR 170s, blood pressure was pretty stable. By the time he got to us, about 112 to 120s. After fluid resuscitation, still stayed at the same airway, or same heart rate. So, cardiology fellow wanted cardizem, which we did have. So that was ordered, and when the nurse was going to give it, she came and got me, said the patient's blood pressure is 80 systolic. I'm not giving cardizem. I said, okay, that's fair enough. So then the next question came, do we need to sedate this kid and shock him? Like I said, he was autistic, so it was a little bit more of a challenge in obtaining mental status, but mom would tell him to do things, he would do exactly what she told him. He was following commands, he had good peripheral perfusion. He was actually had to urinate, so he was obviously perfusing his kidneys and able to urinate. So I did not rush to cardiovert this guy, because he obviously is perfusing his brain based on the assessment that I could do. So the debate came back and forth was, on paper he is unstable, hypotensive tachycardic, with a tachydysrhythmia, so we need to shock him. Then that went into how do we go about it? Do we do chemical? Do we do electrical cardioversion? Still no consensus there. So what ended up happening after significant debate, involvement of cardiology attendings, everybody, was to start him on a phenylephrine drip and then sedate him with etomidate and cardiovert him in that regard, just due to delay in getting the meds from pharmacy, ibutylide, propafenone, where the debates, cardiology wanted either DIG or ibutylide, then that was going to take too long, so the debate was somebody be able to manage his airway, do the cardioversion in the ED, should we need an emergent airway. And he ended up getting etomidate, required a little bit of assisted ventilation with bag valve mask, but did okay, and got shocked right out of his AFib RVR, no sinus rhythm. But the debate there was, what is the definition of unstable? And then what is the right thing to do? Because the textbook will tell you that is an unstable patient. When you sit for your boards, that's an unstable patient. You shock that. But when they're awake, talking, following commands, is that really an unstable patient? So, and again, this is a non-invasive cuff. Some blood pressures were being taken on a forearm. They tried to take another one on the leg. So it's just really taking the whole patient into consideration, not just what numbers do you have. So I found that to be interesting. And then another one was a post-cardiac arrest with a rate.
So hold on. So
yeah,
I know a little about this case. So this is like a cool case.
Yeah,
you had somebody. I mean, so we know that flutter is a little harder rate controlled than fib, right? And we know the most common type of flutter is 2-to-1 flutter, which we see most of the time. And we know the most common reason people go into fib flutter is, hypertensive cardiovascular disease, left atrium getting bigger and bigger until suddenly they go in it. And we know that roughly if your left atrium is bigger than Spencer's article, you believe 4.5 centimeters, it's really hard to convert them out of it, right? So, and we know that if you convert somebody with a clot in their left atrium or smoke in their left atrium on echo, that it makes them high risk of having a stroke when you convert them. So the job in the acute setting is not to convert them, it's to rate control them, right? And we know that sometimes people are really challenging. So you gave multiple doses of an AV nodal blocker and it didn't work, and we're all having all these shortages of stuff. So what do you do when the blood pressure is not great? And one thing is you can titrate up your AV nodal blocker slowly. But somebody wanted to give phenylephrine, which is somewhat of like what we do in the ER. We oftentimes, for people who are hypotensive, will give a push dose pressor, and that's what their goal was, to get their blood pressure up. Because we know that ACLS would have you believe if somebody looks at you the wrong way, they're unstable, which we don't believe. We believe that, the most important question to ask any patient is, how are you doing? And if they turn around and say, I'm good, how are you? Well, that's airway, breathing, circulation,
Exactly.
mental status, everything else, right? Doesn't necessarily matter what their answer is, as long as they're making sense in it. So those people, we generally don't rush to cardiovert. If their brain's still perfusing, then we give them an AV nodal blocker. And DIG takes too long to work on the AV node. That's why we don't routinely give them the emergency department. I mean, one big paper that was done a few years ago in the cardiology literature was DIG takes 11 hours on average to work on the AV node. And sympathomimetics override DIG at the AV node, which means this is why we used to digitalize everybody in medicine, and we kind of stopped doing it, because you put somebody on DIG chronically as an outpatient and they exercise, the sympathomimetics override the DIG at the AV node. So if they have a history of AFib chronically or A-flutter chronically, then they get up exercise and they get tachydyspnea again. And you can give IV DIG, again, it takes a while to start to completely block the AV node, I should say 11 hours, not partially. And people always say, I gave DIG and they converted. And the answer is, no, not really. You gave DIG and you rate controlled them, and then they spontaneously converted, because DIG doesn't cause anybody to convert. The risk is certainly that if they have a white complex tachycardia, you cannot give DIG, right? Because DIG, while blocking the AV node, also speeds conduction down bypass tracts. So if they have a WPW that's underlying, and you block the AV node what's being conducted on the bypass tract, and they're an AFib, and they have a WPW, you could cause them to go into 400 to 700 beats per minute going into the ventricles, will cause them to go into VF, and then you'll kill them, right? So that's why we don't do it for WPW. Another treatment, an old standby that people still do actually, is to get magnesium. Magnesium actually works on the AV node and slows conduction. There's a famous old article which compared cardizem to magnesium, and subsequently magnesium worked a little bit better than cardizem. So you see a lot of, I don't want to say older people, but you see people who have been around a while doing this, and sometimes they're giving magnesium to slow conduction through the AV node. It's like an old trick, and you can give like 2 grams of mag to somebody in rapid AFib if other drugs aren't working. It's something to consider. And it's even for people who have mags over 2, which is what we always want to achieve. But so they gave basically push dose pressor, and they chose to try and cardiovert somebody. Maybe that is probably okay as long as you do an echo and you think you can see the left atrium pretty good.
Yeah, he had an echo, and the left atrium wasn't dilated. You couldn't see the left
Right.
atrial appendage because it was a TTE, but
Right. So
it
you're
was
looking for smoke, basically.
Yeah.
Smoke in the left atrium, because you may not be able to see a clot on a regular thoracic echo.
Yeah, and it's one of those, it was a overall healthy patient that didn't have underlying cardiac disease, and it was suspected of a sudden onset AFib. So, had been feeling fine the day before, and then all of a sudden is having this. So,
Right. And there was a study, actually, I remember years ago at Hahnemann in Philadelphia, where they actually took all the people coming to the ER with AFib, and they did transthoracic echoes on them in the ER, and if they saw no smoke in the left atrium, they just shocked them all. And then they sent them right home from the ER. It's hard to do that. It's very hard to do that. And if I remember right, they did actually transesophageal echoes on them, not transthoracic echoes.
Oh, okay.
So, which anybody can do with proper training.
I've been on an electricity kick apparently the past month, because I cardioverted an anticoagulated AFib RVR patient at another facility where I work. She went home about 30 minutes later. She was so thankful that she didn't have to stay in the hospital.
Right.
She was already anticoagulated, compliant, shocked her, and she went home.
And by the way, what you're talking about is chemically cardioverting with drugs, and we do know there are certain drugs that can chemically cardivert very well. Propafenone, 600 milligrams for the average adult, is very well liked in the EP literature. 600 of propafenone can chemically cardivert you pretty quickly. Ibutylide is an old drug not an old drug, I remember when it actually first became available that people liked, but the problem was it prolongs your QT interval. So the argument is you have to put them on a monitor for a period of time, which is debated in the literature. But I know one EP guy who loves propafenone 600 milligrams, and I know one EP guy which hates it and gives everybody ibutylide. I think we talked about this.
Yeah,
so
we
they
did. don't
don't always agree with each other, but ibutylide is a way to convert somebody, or propafenone 600 milligrams, but you need to echo them first.
And yeah, I say it needs to be after an echo, and propafenone's PO. Correct. So
Propafenone's
they
PO.
take it by mouth, so you have to
Right.
make sure they can tolerate oral intake
Right,
as well. So that was something that we had talked about during this case was,
right.
can you tolerate oral intake? And he could, but we did not choose to go that route just due to the involvement of other services. So.
Yeah. The what's your other case?
It was just it was a med control call about post cardiac arrest, and they were calling for push dose pressors because the patient was hypotensive after ROSC. So they said, oh, he's hypotensive 51 over PALT. I said, okay, what are the rest of his vitals? And his end tidal was fine, sats were fine, but his heart rate was 186. So I said, okay, like it looks like an SVT. I couldn't see the image, but I said that needs cardioverted, and they were just dumbfounded that I would have recommended that. And then we went through the explanation, got the patient cardioverted, and they called back and were so excited because he now had a heart rate of 64 with a STEMI and a heart rate and a blood pressure 120s over 80s. But it's something that I guess is not frequently done in the pre-hospital setting. I feel like we get more calls to transcutaneously pace patients than we do for cardioversion.
Yeah.
We just become dependent on low pressure or cardizem or verapamil, whatever we have that day.
Poisons work, right? And if you're a patient who's not got a great blood pressure, you can start a little bit lower and titrate up.
Mm-hmm.
Right? Our biggest problem now is we're running out of them. We're running out the Tizem, we're running out of low pressure. We're doing a verapamil in service. What happens when we run out of verapamil? What happens when we have nothing left to block the AV node?
Electricity.
Right?
Everyone's going to get electricity.
And we talked about this too. I think a couple of drunk clubs ago, I had a patient who I got called for, which was an SVT that was like 180, 190, and somebody a little bit older. So you worry about them a little bit more, and they gave 6 of adenosine, then 12, and the patient was completely asymptomatic, but their heart rate was like pretty high. And they wanted a cardiovert. And I said, let's just try a third 18 of adenosine. And it worked. And they called back going, oh, this was great, we didn't think about this. And I'm thinking, I didn't do anything good, I just got freaking lucky, right? Because I was expecting you to call me back and saying it didn't work, but I just got lucky. And somebody taught me years ago, an EP guy said for every 6 milligrams you give of adenosine, 1 milligram gets to the heart. That's why in the EP lab we give 1 of adenosine, not 6. I mean, there's a saying that, 6 of adenosine converts 80% of people, 12 converts 93%. Depends whose articles you read. But I just gave 18 for no good reason. Then I said, we could give this patient ketamine and fentanyl, and maybe we're going to go ahead and sedate them properly. But the patient's that asymptomatic. What's the downside of just trying 18 of adenosine, right?
There's none. It just goes away.
And it may certainly make you feel terrible when you give it.
Well, where I trained, one of our EP guys, when he did his fellowship, he said they didn't touch 6 milligrams of adenosine. He goes, it was first dose was 12, second dose was 18. That was all they did. So we did it regularly in residency. I mean, there were multiple times where.
Right. I guess it's a question. Why don't we start everybody at 12? Why do we start at 6?
Yes, his debate was, if 6 doesn't work, then you're going to go to what, 12. If 12 doesn't work, then what are you going to do? He goes, I would recommend go to 18. So he goes, now you're making this person uncomfortable 3 different times, not just once or twice.
I think that's one of our research questions, and we just never had time.
Yeah, it's a good point. We probably just started at 6 because somebody told me and I told somebody else, and so forth and so forth. It's not based upon any science.
Yeah, and that's kind of what he was like. He goes, ACLS is going to tell you this, but he goes, we know a lot of ACLS stuff isn't necessarily the most evidence based. Like we mentioned earlier, epi can get a pulse back, but how many people walk out of the hospital? That's not the reason.
It's the same reason why we did stock shots before.
Right.
So that's what we started with, and we just never changed. Mm-hmm. The other thing is also they may have just had tunnel vision. They just saw low blood pressure, and they didn't think that the low blood pressure could be because of the high heart rate, that the heart is not filling, and you can't pump what you don't have. Yeah. That's a lot of times with rapid AFib as well. Mm-hmm. If they're hypotensive, sometimes I think it's rapid AFib. If we convert the rate control them, their blood pressure will most likely come up.
Mm-hmm.
Yeah, I mean, you could either block your AV node first or vasodilate them first, like when you give verapamil. And, so what's going to happen? I don't know till I give it.
Yeah, right? Exactly.
But if the blood pressure is not perfect, and we did a journal club too on the benefits of giving calcium chloride before calcium channel blockers, and there's not great science. I mean, you can do it, right? When I was in medic, we always did that. Every time we gave a calcium channel blocker to somebody, we gave 1,000 of calcium chloride to prevent the hypotension. But when we looked at this literature, it's not very good literature, but there's no downside, right? So every now and then, somebody still asks me for it, and I usually just say fine.
Just say okay. Yeah.
Right. I don't know if they mean that they think that means I'm endorsing it, but I don't know that it works. I don't know that it doesn't work. I mean, the literature doesn't help to answer the question that well, so why not?
I don't think it does any harm to give it. So it's like risk versus benefits.
Yeah.
I usually will
typically-
hydrate my patient as we're getting ready to
Yeah.
rate control them.
Yeah.
And sometimes that alone will just rate control them.
I mean, by and large, I typically like to do it if it's under 100 systolic. I'll still give them calcium chloride. That's because I'm a fan of calcium chloride. So.
Me too.
I mean, so when you were a medic, did you give calcium chloride before a calcium channel blocker?
Yeah.
You did? To everybody?
Routinely, it was almost everybody, yes. But now
Yeah.
I don't.
Right.
Yeah.
So if a resident doesn't do it, will you stop the resident? Tell
No,
them?
I'm okay with it. I mean, because at the end of the day, you know this is end-diastolic filling. This is a problem
Right.
of end-diastolic filling. And so as soon as we chemically cardiovert and we control the rate, now we have increased end-diastolic filling, we're going to have a greater map, and our blood pressure is going to come up nicely. It's, we talk about this transient phase of hypotension that we potentially could have after the actual initial dose of the antiarrhythmic, but I mean, it's only short-lived, and I think it'll always resolve. So I'm really not, I'm okay with it if you don't.
Yeah.
So
I mean,
I want
in your case, I'm sorry,
okay.
just to mention is that, there's no argument about if your patient's stable or unstable. A cardiac arrest with ROS, who's got hypotensive and they're tachycardic, you don't have to worry about that. You just shock that patient right away.
And that's why I wanted
You
to
know?
discuss both cases, because you had
Right.
one that was perfusing the brain and
Absolutely.
calling unstable, but then you have a post-cardiac
Yeah.
arrest unresponsive,
Yeah.
that's unstable, in
Right.
my view, like you said.
Absolutely. So there's no argument about that. You just give them some electricity, call it a day. You don't have to, mull around on that one. So that's pretty easy, straightforward.
But I also
and
give
you
calcium.
do see that from time to time. A lot of times you may think, is this epi-induced? A lot of times they've given a lot of this epinephrine, and you're probably not perfusing. As soon as you can start perfusing now, you've got a lot of epinephrine that's circulating in the body. Could this be all epi-related? 180 I think is still pretty high. I would still shock that.
Yeah, and and the funny thing is when they called out, they were looking for push-dose epi, and that was it. They were very surprised when I told them, synchronized cardiovert this patient, give them calcium as well,
Right.
and they were like,
I mean,
we do
180
have calcium, because again, that was a
if it was a
shortage.
20-year-old, I might have said, it's a 20-year-old 180, they could probably tolerate it for a couple of minutes. Let's
Yeah.
just give 5 minutes and see if the epinephrine wears off and the heart
Yeah.
rate comes down.
Right.
If it's somebody 70 years old with a bad EF, they probably can't tolerate that 180 because it
Mhm.
affects their EF more. Just like that AFib, how much does AFib diminish your EF, right? It depends, let's say it's 20%. It depends how much will that affect you. It depends what your normal EF is.
Yeah.
Right? Some people it doesn't affect them at all. Some people it affects them a lot.
When they were able to slow down the echoes, I watched them do part of the echo, and they were able to slow it down, and he had great, excellent squeeze. That
Just
wasn't
not
the
fill.
issue. It was
Right.
they needed to fill. It was just like we had already talked about.
And
It was
maybe
a
you could have
filling
given an
issue.
antiarrhythmic, which probably wouldn't have worked so well, like procainamide or something.
Yeah,
but
sure.
it would have taken a little bit to load. And what does procainamide induce? What disease? So besides prolonging your QT interval and causing hypotension.
Drug-induced lupus.
Lupus.
Yeah.
So
Lupus.
procainamide
Yep.
induces lupus.
Couldn't remember which one.
How do you? What's lupus? What's the word lupus mean?
Wolf.
Wolf. Right. Lupus means wolf. All right. So. All right. Any other interesting cases? Who else was pre-hospital this week?
And Jocelyn Janae.
Anything interesting on the road?
I mean, we had a kid who had an allergic reaction, and he got epi in the field, and we tried to give him some steroids. We tried to get him to drink it in his juice cup because they couldn't get an IV, and that didn't go very well. But he did fine.
So Decadron.
Yeah. Well, they had Solumedrol, and then we gave the Decadron because the medics didn't have that. So yeah.
So all right. So I'm just having a flight of ideas. Somebody at home tell me what the right dose of Solumedrol is. So I still can't figure it out from the literature. I know that for years we've been giving 125 milligrams, which is completely made up. We just actually changed it on a statewide level. And when I say change, we wrote the protocol, which will come out sometime in the next year or two, and from 125 to 60. So we'll be giving 60 to everybody. So although I've looked through the literature, I cannot find one paper which has compared 125 to 60 in some sort of prospective or randomized trial where we actually have shown 60 is better. Although I do fundamentally know that you probably don't need to give 125, that 60 is good enough, and I also know that many of my ICU colleagues are just starting out at 60 when they hit the unit, and you really don't need 125. So we're going to see a movement, at least in our state, we're in New Jersey, about giving 60 soon instead of 125. because 125 was just made up. We give it because that's the way it comes. But we're all going to switch to 60 soon. And then, what else did you do? We give Benadryl because that's what we have.
Yep.
One more time for the 100th time. Benadryl is only good for rashes and itching. Does nothing for if you're short of breath. PO Benadryl takes 100 minutes to start working. It's a silly drug. And if I'm sending somebody home from the ER, I typically give Zyrtec because there have been comparative studies, fair studies, which compare Zyrtec with Benadryl to show Zyrtec's a little bit better. Plus, it's easier for mom to administer to their kid than around-the-clock drug, which is going to make you tired. Although Zyrtec certainly makes some people tired, it doesn't make other people tired. Most people will get tired from Benadryl. But we give it pre-hospital because that's what we have. And we can give, I like Dextrol a little bit better because it lasts longer than Solumedrol. I was just covering, but Solumedrol's okay. I was just covering a Yankee game and we had no Decadron, so we gave Solumedrol. But what I did was I made sure somebody's going to go to the pharmacy and get their PO dose right away. So this is what I typically do in the emergency department. I'll give an IV form if I'm worried about their airway, and if I can get them better enough to go home, then I'll give them their PO dose before they leave. So at least I know they're covered, so I don't have to worry about the Solumedrol if I'm giving that stuff Decadron wearing off. I know they have the PO drug in their body. You guys do the same thing?
Yeah, I usually send my allergic reactions in the ER home with Benadryl if they need it, and then
So now you're switching to Zyrtec.
right, and then I give them like 4 or 5 days of the steroid, and then I give them the one dose PO before they go if they got.
Yeah. And then for me, always, if somebody had any type of somewhat real allergic reaction, I'll give them a prescription for EpiPen.
Yeah.
Right. And we have a terrible protocol in New Jersey which separates EpiPen Junior from EpiPen Adult at 40 kilograms. No. 4 years old. Yeah, 4 years old. Right, which is really silly because you don't give drugs based upon age, you give your drugs based upon weight, right? But we did that based upon tradition, like most of medicine. Right. The truth is, for me, if I'm having an allergic reaction in front of me and they're not dying, they don't need IV Epi, my first dose of Epi, first of all, it's all IM, not sub-Q. I usually start at 0.5. Is that how did you guys train?
Do 0.5.
0.5?
I was trained 0.3.
0.3?
Yeah.
My guess is nobody's done a randomized trial to compare 0.3 to 0.5. But
When you look at the dose range, you could do 0.3 to 0.5, obviously, but typically if they're elderly, I'll hold off as much as I can as far as the 0.3 versus 0.5. Anyone young, they get 0.5 right off the bat, because if I feel like I need to pull the trigger with Epi, I'm giving a higher dose.
Right.
If they're elderly with comorbidities, I try to give them at least a lower dose of 0.3.
Right. I mean, Jim, I remember, was it 2 or 3 years ago, you gave like 1,000 milligrams for Epi. Tell us about that case. That was a bad allergic reaction, right?
Yeah, it was a 75-ish year old lady out in her backyard, got stung by several yellow jackets, and then had a severe allergic reaction. She got an auto injector pre-hospitally by the first aid squad, which did a wonderful job. Those guys were great on recognizing the signs and symptoms. She was short of breath. She had chest discomfort. She was hypotensive, and she was very pale. Her blood pressure was unmeasurable, but she was awake and answering questions. She got epinephrine. We gave her more epinephrine, another 0.5, I think she got intramuscular, and then we managed IV access. We gave her a liter of fluid, and then we started giving her the push dose concentration of epinephrine because her airway, she's still having
So
shortness.
you're giving
of
like
breath.
10 to 20 mics IV push.
So the end of the day, I think she got 900 micrograms or almost a milligram of epinephrine for her anaphylaxis, and she did well. And we ended up leaving her on an epi infusion. We put a milligram of epinephrine in a liter bag and ran that on the way to the hospital. When she got to the hospital, her edema in her face and the angioedema came down, her blood pressure recovered, and she had a cardiac history and everything, and did fine with that load of epinephrine.
Right, and her,
No change in
and if she had
repeat.
lost her airway and coded, her chance for a good outcome would have been much less than if you didn't give her all that Epi.
Yeah.
Right, so for all the people saying you gave too much Epi, you didn't. You saved her life.
Yeah.
Right?
I mean, the antidote is epinephrine. I mean, when your capillaries are wide open and you're swollen from vasoedema and you're dilated out from all the mediators from the allergic reaction, the immune mediators, you got to fix the blood pressure. You got to
Right.
perfuse the brain. You got to perfuse the heart. I mean, you're more ischemic from having a blood pressure of unpalpable or 50 than than inferred or made up vascular.
Right, and you did all the silly things, like you gave her Benadryl and you gave her Cimetral, and you gave her all the things that don't work in 5 minutes, right, or less.
Yeah.
Because we're not saying don't do that, we're,
She got the whole
and then-
package, but she
And then
loves Epi.
when she went to the ER, somebody probably sent her home with all the usual stuff, but then they gave her an ACE2 blocker too. Despite only limited evidence, they just said, why not give her some Hep C to go home with too?
We got a little, I'll say it politely, amazement, like, you did what? And we rolled in with an Epi infusion and all that, and post-Epi in a 7-year-old, but I truly believe she would have died if she didn't get it.
Right. So this is what I say, we're getting too good at pre-hospital medicine, so when we get our patients to the emergency department, they're starting to look really good. Because we're being more aggressive and taking really good care of, so we're getting, you did all that, but she looked so good.
Yeah.
You should have been here 2 minutes ago.
Right?
And the reason why we are emphasizing that, Benadryl, the steroids kind of help symptomatically and don't work right away is because the big thing is the epi that makes a difference. Don't spend 5 minutes trying to get the Benadryl ready and have the epi in your hand and not in the patient. Put the epi in the patient, and then you can get the Benadryl, the Cimetral, and everything else.
And after you give an intramuscular epinephrine once or twice, I mean, the literature we reviewed after this case a couple years ago is you give your first dose of IM epinephrine. If you're not better in 8 minutes, you need to repeat the dose and then give intravenous concentrations. And we found out, we teased through the literature, that the push dose epinephrine, 1 to 100,000 concentration, or 10 micrograms per ml, and given 30 to 40 micrograms at a clip, is the same push dose concentration that we were given was effective in the literature. It was, I think we found that in Rosen's, and we found that in some peer-reviewed literature as well when we were looking through the anaphylaxis literature at that time.
I even think 8 minutes is too long.
Yeah, I mean, that was the maximum absorption from what we looked at when we looked at the differences between auto-injector and IM versus sub-Q and whatnot, and the best is an intramuscular dose, and then if you're not better in 8 minutes, it's time for more.
I mean, I think one of the things that we do poorly is the first dose even is probably prolonged. And a lot of times, we can't stress this enough, and we kind of beat this with a dead horse, but any respiratory component in any type of allergic reaction, you need to pull the trigger and give the epi. People start giving albuterol and these sorts of things, and it's like that's kind of the wrong steps. Just like Navin said, you don't grab the Benadryl and Cimetral first, get the epi, get it in them, and then you can get the Duonev, and then you can give the other medications. But give the medication that's actually proven to serve some benefit.
Right. Anytime you're thinking about anything too long, just go ahead and do it.
Right.
With
Very
epinephrine.
low threshold for
Right.
epinephrine administration.
I mean, I was working at a new facility and had a patient that was just thrown into me pretty much saying, I think he's having an allergic reaction on someone whose lips, tongue are swollen, he's having a hard time breathing, he's hypoxic and wheezing. I mean, there wasn't a debate, so I said he needs epi right now. So of course, they wouldn't do any epi until I put an order in the computer, so stepped across the hall to put it in. I get back and the nurse is starting a line on the patient. When I asked why, it was just in case their airway goes bad, they need a line so we can intubate them. When clearly the response should have been, oh, is it time for that second dose of epi yet? Because this guy...
This is why being pre-hospital is so good. You don't have to put any orders in anything. You
Yeah.
just get the med and draw it up and push it, right?
And it was great. I mean, he got his first dose of epi. I gave him 3 minutes, and he wasn't better. And he got his second dose of 0.5, and then he looked like a whole new person. He looked great. But I mean, that's what he needed. We did, of course, the Benadryl, IV, and all that stuff.
Yeah, but that can wait.
Exactly.
Like there's certain drugs that should be on hand. That's why code cards are not. They don't have a computer on them, so you can enter in orders. You open the code card and you give the epi to the patient.
And then a pro tip for prescribing is everybody should go home with a prescription for 2 pens.
Yeah.
Exactly.
Yeah.
And if you write epi auto injector, epinephrine auto injector, instead of the brand EpiPen, we like to refer to it as EpiPen. But that's actually the brand. EpiPen Junior is the brand, which we don't endorse any brand.
Yeah.
But if you put epinephrine auto injector, the pharmacy knows how to fill that.
And I have many squads who are getting it now from Canada and outside the United States, and it's less expensive.
Yeah, so it's easier to get.
Although we should say there is a national movement that some people are doing now that's working out quite well for BLS to drop epinephrine. We have a study that's going on, a shout out to Andy Lovell, so we have a study that's going on in Gloucester County that has started, and we have a waiver in to start having BLS drop epinephrine in the state of New Jersey. We pulled all the literature, and although most of the literature is on nursing students doing this, The literature says that generally, if if you're being trained to drop epinephrine and give an IM shot, and you don't do it for 4 months, that's when you need to get re-education. So 4 months seems to be the turning point where you need to be re-educated if you haven't done it for your BLS. So there are places around the country, around the world that are doing this now, and more power to them. It should be done because now, because if somebody pre-hospital today had an anaphylactic reaction, we wouldn't be using an EpiPen. We'd be drawing up the epinephrine because we could control the dose, and it'd be much cheaper to do. So it'd be good for the patient, and it'd be less cost-effective. If it was us, right? If it was us.
And there's also new syringes out on the market now I've seen and used that when you completely depress the syringe plunger, the needle auto retracts back into it immediately. So
Yeah.
you push the needle in the skin, you squeeze the plunger, so you draw up to 0.3 or 0.5, you squeeze the plunger completely, and that triggers a spring-loaded thing, and the needle automatically retracts into the syringe barrel and is gone.
Right.
They're using it a lot in pediatrics when they're doing vaccines and things like that.
I'm sure you guys were taught this, that when you put a needle into the skin, you're supposed to pull back if you see any blood, right? So it was an official statement about 5 years ago from the American Academy of Pediatrics to say you no longer have to do that. They came out with a physician policy statement that said you can actually draw up a med and just inject it into a kid. You don't have to actually see if there's any blood. And if you think of it, well, who cares? So you hit a little capillary. What does that matter? But the AAP came out with an official position statement.
I know some people who can't hit a vessel when they're trying to.
What an interesting pre-hospital cases. Anybody else? No. All right. Let's go to Dr. Weingart's. So here we start again. So we'll start with the. What do we want to start with? Which question? What is the rationale for providing pre-oxygenation before tracheal intubation? Who wants to take this?
Anyone?
Anybody? Anyone?
Jim, go ahead.
I would say I can do it if not. It's not a big deal.
I think it's up at the
You
very
just
top.
go around the room.
Okay. Yeah, that's fine.
Yeah, I think
Alright.
it's like the
So essentially,
There you go.
so
It's right at the
obviously
top.
we talked about this Weingart's article about
Yeah.
pre-oxygenation. So we wouldn't be talking about this article if there wasn't a good rationale for providing pre-oxygenation and tracheal intubation. So essentially, what you want to do is you want to continue to provide oxygenation, minimize hypoxemia, especially during the apneic period. So you're extending the duration of safe apnea, essentially. So that's essentially what you want to do. And it talks about the status when there's in the article, for those of you looking at it, figure 1 shows the oxygen hemoglobin dissociation curve. So when patients desaturate, you want to make sure they don't slide down that curve, because when you start getting into the lower oxygen PaO2, you start getting into high risk pretty much for bad things to happen. So your patients become hypoxemic, and you can have a million other things happening after that. So that's the rationale, essentially, is because you want to prevent bad things from happening. You want to try to increase and extend the duration of the high oxygenation during the apneic period. It talks about operative patients, some anesthesia literature in here as well. But we're always taught, like, oh, how long does it take for a patient to desaturate? 8 minutes. And I think it talks about this later on in the article also. But that's for a perfect, normal, healthy person breathing normal tidal volumes. If you're going to intubate a patient, chances are that's not what's happening with normal physiology. So it talks about, like, a patient breathing room air before rapid sequence intubation. They have a PaO2 of 90 to 100, and you have about 45 to 60 seconds.
So what's normal PaO2?
It depends on the base,
60 to 100.
but it should be right around 80 to 100 should be about.
So 80 to 100. So what if you're 100 years old? What's
Like I said,
normal?
yeah, it depends on all on everything else, but it's going to be 60 potentially.
So there's a formula. There's two formulas. One is the actual formula in medicine, and one's a cheat formula. The more complicated formula is what's in the pulmonary textbooks, which is 109 minus 0.43 times your age plus or minus 5. That's what normal PaO2 is. But you can actually, the cheat formula is 100 minus 1/3 your age. So 100 minus 1/3 your age. If you live to be 100 and your PO2 is 58, that's not so bad.
That's pretty good, yeah.
Right? That's much different from somebody's 20 years old. So, those numbers that are 60 to 100 depends upon a lot of factors.
Yeah, and that's why I think that's one of the few things that has such a broad range, because in a young, healthy person, I would expect it to be closer to 100.
Yeah.
And if, like, I had a patient the other day that was the same thing, that I don't feel the patient needed intubated. His PaO2 was 54, but he was 92 years old with
Yeah.
multilobar pneumonia. I said, that's pretty good in my
Yeah.
textbook. But it flagged on the ABG as low.
I
and
mean,
panicked.
if he was on room air, of course.
Yeah.
Yeah.
Well, his first one on 10 liters was, I want to say like 69 or something like that, and then
Right.
got a room air ABG, and his sats were like 80.
Yeah, because perfect
86,
PO2,
87.
it depends on what you're, where you are at sea level, but it's 760. I mean, and then you get back a PO2 of like 500, you go, that's amazing, or 600, that's amazing. Right?
Yeah, exactly. So, again, this is what we typically think of in normal healthy patients. PaO2, it's saying 90 to 100. You have about 45 to 60 seconds between the sedative paralytic and the airway. So you have about 45 seconds, and that's a room air breathing patient, no pre-oxygenation. And then again, this is some of the anesthesia literature that was looked at. But what they talk about in the ED, it says that you can increase how long that 45 to 60 seconds by administering supplemental oxygen. So in the ED, it says 3 goals. One, bring the oxygen saturation to as close to 100 as possible. It's one of the few times we want to do that. Denitrogenate the lungs. So you want to maximize oxygen storage, not you want to denitrogenate. So as much as we're pre-oxygenating, we're denitrogenating the lungs. And then you want to denitrogenate and maximally oxygenate the bloodstream in addition to the oxygen in the lungs and the storage in the lungs as well. So that's pretty much what this first section of the article is about. Is why do we do it? It's because it extends this duration of safe apnea and allows us to maximize oxygen storage in the lungs and denitrogenate.
Okay, I'll take it. Sounds good. What's the best source of high FiO2 for pre-oxygenation? We can just go around, Jim.
Yeah, the high flow nasal cannula they found is beneficial because you can use a simple, regular, and this is where I think it was first defined, or somebody came out in a paper to first define this as a regular nasal cannula can go on their face with Levitan, the no DSAT protocols and stuff, that you put the nasal cannula on, a simple, regular nasal cannula underneath any mask, a bag valve mask, a CPAP mask, whatever. You still get the mask seal, and then with just a high flow nasal cannula with 15 liters per minute, you get the close to 100% FiO2 as you can get.
Right, and first in the pre-hospital setting, that means an extra D tank or something, which is okay, right? No big deal,
Yeah.
right? We're saving people's lives.
Sure.
Or it can be maybe your SC2 carries a second M tank or something, right? That happens
Or
sometimes.
a splitter port. There's always
Right,
more
splitter.
than one tree in the ambulance.
Right. Or maybe you're in a place that has humidified oxygen machines where you can have a kid with bronchiolitis and you can get up to 20, 30, 40 milliliters per minute.
That was an article by Patel with the Thrive method that we talked about at
Right.
the conference. Thrive described the 40 liter per minute humidified.
Right.
And they used anesthesia patients.
Right.
Their head would not.
And more for transplants or transfers, right, Alex? We're getting people who are not intubated who are on 30 liters by nasal cannula, right? Who are putting on airplanes, and we're doing that all the time.
Yeah, and I think the big thing, and I didn't mention in the article, is that you can have discomfort if you're not having, through a nasal cannula, if you don't have humidified oxygen. So especially if it's a transport, make sure make sure that you can humidify that oxygen they're getting delivered. Otherwise,
Right.
patients aren't going to tolerate this stuff.
Yeah.
Right,
So-
and we go through
Right,
oxygen tanks very
absolutely.
quickly
Yeah.
when you have a long fixed-wing flight,
Exactly.
and that's our challenge, and we can't get the oxygen concentrators. Nobody has yet has made us an oxygen concentrator that can get up, really past 6 liters. That's our big problem. Okay, what period of time should the patient receive pre-oxygenation? Who's that?
Me? Oh, we're skipping? These two don't have to go? Oh, I see what it is. So this section basically focuses on acknowledging that patients with adequate respiratory drive should get pre-oxygenation for 3 minutes, or they can take 8 breaths, like vital capacity breaths, full inhalation and full exhalation. They do comment on, obviously, most patients in the ED, like Alex was saying earlier, can't take vital capacity breaths, so they're not at peak health if you're to the point that you're intubating them. But if they are and they can, then they recommend 3 minutes or 8 full breaths in and out.
So I know they talk about this later, but it's like the pulse ox lag, right? When the pulse ox isn't coming up and you just go, I've only squeezed the bag of death 3 times, and the answer is just wait a couple of seconds, right? The pulse ox is going to change. Things are looking better. The heart rate was just 180, now it's coming down a little bit. Or maybe the patient's bradycardic, now they're not bradycardic anymore, the extremes are going away. A couple of more squeezes of the bag of death, maybe they're about to get better, right? But people say, oh, pulse ox is 70, pulse ox is 50, pulse ox is 40. Everybody starts screaming, and you just go, we're in the hospital, just relax. It's not like it's the pre-hospital setting, right? This is what we see all the time in the ER. Or it just makes me say here that you know, one of the most important forms of critical care medicine is no BP, no pulse ox, right? If your blood pressure is 60, you're not getting blood to your fingertip, and subsequently you're not going to get a good pulse ox reading. Maybe it has nothing to do with your lungs, maybe it's your sepsis or your blood pressure and everything else. Or maybe, most commonly, maybe something silly like the blood pressure cuff just inflated, and that's why you're not getting a good pulse ox, and we can all stop screaming. Okay, can increased mean airway pressure augment pre-oxygenation?
So in this section, they're kind of wondering if besides apneic oxygenation, you know, is there any other way besides oxygen alone that we can improve oxygenation? So, and what they're referring to here generally is the augmentation of using CPAP or BVM with the PEEP valve in order to increase oxygenation. So there's a table in this article which shows several different studies that kind of looked at these in different ways with different endpoints, and they were looking to see if this increased or decreased rather apneic oxygenation times. And in general, they did find that with the use of either CPAP masks, non-invasive positive pressure ventilation, or using PEEP valves on a BVM, they were able to achieve this. And kind of the goals that they worked with were after 3 minutes of pre-oxygenation alone, if a SAT between 93 to 95% wasn't achieved, you know, would this help? And they did find that it did. And the reason why this probably helps is due to shunting. So in very, very ill patients who don't demonstrate normal pulmonary physiology like we talked about before, the alveoli, the smallest parts of the lungs, are either collapsed or filled with fluids. So is there a way that we can stent them open, pop them up, and help? And in these cases, they were able to do that.
Sounds good. And then in what position should the patient receive pre-oxygenation?
So usually, you know, when you're actually about to intubate or something, you might have them in a supine position or something, but usually during pre-oxygenation, you should really have them sitting upright. When you're lying flat, your diaphragm is kind of impeding your lungs from actually expanding, whereas when you're actually sitting up, your diaphragm is low, and you're going to actually fill up your lungs with air, preventing, and it kind of prevents atelectasis as well. I mean, there's been a couple of studies done before showing that if you have your head above like a 20-degree position or even higher, you actually improve your pre-oxygenation. So that's kind of what we would recommend. Obviously, you also have patients with like spinal injuries that have to be immobilized, and they're recommending basically reverse Trendelenburg positions if that's the case.
Okay.
I would say to add to that, I mean, I had something that I still remember and still discuss when we do airway, especially with teaching, is positioning. What we talk about is the whole goal is you want to decrease, or you want things that you want to minimize things that decrease functional residual capacity. You want to increase FRC as much as you can. And some of the things you can do something about, some of the things you can't. So one of them is positioning. A supine patient will have decreased FRC. So again, this just supports that. You want to put them in an upright position. Female patients, you can't change that. Obese patients, you can't change that at the time. And then paralytic also decreases your FRC. So you have control over 2 of 4 of the factors. So do what you can. If you can put them supine, increase their FRC while oxygenating them, I think that's perfectly reasonable.
So is there anybody we want to lie down flat anymore? I mean, I guess the patient who is like the MVC patient who is acute neurologic deficit, right?
Yeah. But even then, I mean, most neurologic injuries, you want elevation of the head of the bed. I mean, obviously you want to minimize
Yeah, but like they
for
can't
spine
move their
trauma.
arm, and they
Yeah.
take a spinal cord injury.
Oh yeah, everything's spinal cord.
After an MVC, so we lie them flat. Is there anybody else we lie flat anymore? No. So anybody in general short of breath, no matter what can we say anybody short of breath, no matter what the cause is, should be sitting up as much as possible.
With a nasal cannula.
With a nasal cannula.
Yeah.
At least.
Well, this
Right.
article is recommending a 30% reverse lumbar position for a spinal revision.
Right, so, and, we said that before too, so 30% sounds pretty good. I mean, if we knew they had a fracture and put a TLSO brace on, we'd want to keep them flat. So, right, so if we don't know they have a fracture, what's wrong with sitting up a little bit? But, this article is also written for the emergency department more so than pre-hospital arena. I mean, the pre-hospital setting where you have no idea what their injury is, and maybe they have like an AOD or something significant. I mean, to have them lying flat for a brief period of time, is probably the right thing to do.
If they're laying flat and you were to move the stretcher into a Christian delaware position,
Oh, I think that's okay.
their anatomy would still be straight. but
Yes.
They'd be in a 30% heads-up position, which is what they're recommending.
Yeah, that's why I think it's fine.
Yeah.
Yeah, if you take that away, I agree.
Yeah, you just gotta somehow get their body to be flat, but the stretcher up.
Do all stretchers do that? No.
I think so.
So just some stretchers, all right. How long will it take for the patient to desaturate after pre-oxygenation?
I say I'll take this one. We'll go back to you. So this, so the long or the short answer to this is we have no idea. It's impossible to predict how long it's going to take. What the primary benefit is, you want to create a reservoir of oxygen in the alveoli. So the more you can do that, in theory, it should be longer. So in one of these, in this, it talks about how 450 ml of oxygen is present in the lungs. It increases to 300 or 3,000 ml when they breathe 100% oxygen for sufficient time to replace the nitrogen. So essentially, what it says is healthy patients' duration of safe apnea on room air is 1 minute, which we talked about, with 8 minutes when they're breathing a high FiO2. So that's where you kind of hear about this 8 minutes. But again, we're talking about healthy people. So if for someone who has underlying CHF, pulmonary edema, let's slap on a pneumonia and COPD on top of that, because why not? You can kiss 8 minutes goodbye. It's not going to happen. So I mean, when it talks about different studies that have looked at it, and there's just no real good answer. And at the end, it specifically says there are unique variables involved, and it's impossible to predict the exact duration of safe apnea. So we have no clue. Our job is to increase that time.
I mean, the safe time is more than 2 seconds, because I think that's what a lot of people think. As soon as they stop breathing, they'll start desatting. But it's not. So 8 minutes. I think this was this military recruits or medical students that they did this on.
Military recruits.
It was military recruits. They literally pushed succinylcholine, put the high flow, and then just watched and waited until they desatted.
PO2 of 100 for 100 minutes.
They intubated them,
Terrifying.
and then.
We do that on the fellows in December, don't we?
Well, we're not supposed to talk about that.
Like I said, they just got IRB approved.
I'm a Malapati 1, so you're good.
Are you?
That's why we had the bronch.
Can apneic oxygenation extend the duration of safe apnea?
Yeah, absolutely. We were just talking about that. One thing for not only extending the safe apnea, I think one thing this article does that's new to the literature was risk stratifying the patients, so you can know ahead of time who's going to be high risk, low risk, and based on their pulse ox. So Weingart and Levitan here in this paper risk stratified their patients based on that desaturation curve where it's shaded in figure 1, but also in table 2 of the article shows that based on their pulse ox on a non-rebreather before induction, you put them in a low risk, high risk, and a hypoxemic, and that'll give you some time to know who's going to desat on you and who's going to more likely to desaturate on you for the safe apnea time, or will have less safe apnea time.
Right. Anything else for that section?
The risk stratified part?
Yeah.
Yeah, so based on that pulse ox number, so if you have somebody on high flow O2 from a mask and they're still hypoxic, the treatment for that is going to be PEEP. And Weingart goes through his thing where he starts introducing his PEEP valve. So PEEP is what's going to overcome shunt. And shunt is the VQ mismatch, where you have a ventilation versus perfusion, where you have alveolus or portions of your lungs that are not being ventilated but are being perfused with blood. And that desaturated venous blood is mixing with the parts of the lungs that are working, and it drives your saturations down low. So that's how you can be on a non-rebreather and have a low pulse ox or a mid-90s pulse ox. And on a high flow nasal cannula or a high flow oxygen mask and be hypoxic, to fix that is going to be shunned. So you're on any kind of supplemental oxygen, you're still hypoxic. You're going to need PEEP to do that.
And the best video we have for PEEP is a turkey video. Can we play
Yeah.
that? Is that hard to do?
I mean, we can put a link on the website.
Put a link.
So I mean, to understand PEEP and atelectasis is this turkey video where actually once you see PEEP added and the alveoli open up, like you never forget it, and it's so like impressive to the point where I can say if you don't have PEEP on your BVM, you're always doing the wrong thing. Very simple. One more time, if you don't have a PEEP valve on your BVM, you're always doing the wrong thing 100% of the time.
Can I plug another physician team and point you to another
Yeah.
cadaver video? It was one we showed at the EMS conference. It was George Kovac and his AME project, the airway management, or airway. It's AIME, I think is the acronym for his company. But George Kovac has a cadaver video that shows a lung window, a PEEP valve, a high flow nasal cannula, the BVM, and how the difference between the atelectasis is with the PEEP valve, and you can see a human lung through a cadaver video. And it's a phenomenal 2-minute video on YouTube. And just a quick search for Kovac.
Yeah, maybe we can put a link onto our website too.
Yeah, and the guy's an educator. He seems like he's very intelligent, and he's got a great airway program that he's putting out there for pretty much full, free information.
It's great.
The turkey lung is easier to find though.
Yeah.
Cadaver lungs are a little.
It's hard to find.
Yeah, yeah.
But it's just much more impact. There's more impact.
The video's
with
well
that, too.
done.
Mhm.
It's short.
So here's a key question. When and how should we provide manual ventilations during the apneic period?
So this section talks about the BVM, or the bag of death, as you like to call it, and when you should use it and how often or how fast you should use it. And they comment on the fact that if the inspiratory pressure is greater than 25 centimeters of water, that that's the point when it's going to overwhelm the esophageal sphincter, and it can put air in the stomach and increase that risk for regurgitation and aspiration. So if you're going to use it, they recommend potentially using a automated device like a handheld ventilator with a built-in inspiratory pressure limit, or the bag valve mask with the PEEP valve, so you can watch how much you're giving them. And then if you're going to actually ventilate somebody with the PEEP valve bag mask, you should do it at a low volume and a low rate. So they basically break it down into a couple of groups. If you have a patient that's at low risk for desaturation, like their saturation is greater than 95% in that apneic period, then you don't need to manually ventilate them. You can just do the passive oxygenation. They don't need the BVM, which I think is not something that would, like, as soon as somebody gets sedated, everybody's always bagging. So that's just something to keep in mind. And then
So we're over bagging. We're bagging
oh yeah,
too much.
yeah. And then if they're in that higher risk group, then they you have to sort of weigh the risk versus benefit. And they talk about one of the risks being that you can decrease the venous return in a critically ill patient when you're bagging them too heavily and too hard, and that can cause even worsening hypotension. So be aware of that. And if you're gonna bag, you should do like a low volume, 6 to 7, I think mLs is what they per kg, and do it slowly.
Yeah. So 5 to 7. I remember 6. But I don't think it matters that much, 5 or 6. But I remember 6 mLs per kilo, so smaller amounts.
Mm-hmm.
This is also why my favorite device personally is this new CPR2 device, which is a type of bag of death, which has a manometer on it. So you squeeze it, you can actually see what the pressure is, and this is really important to do. Anything else in that section? And then, right, 25 centimeters of water. There was another study which said 27 centimeters of water, but it's all roughly about the same thing. And what did I want to say? So what about and everybody thinks like I don't like the bag of death, but in fact, if somebody's not breathing or breathing extremely poorly, like you got a bag, right?
Right.
But what's your cutoff point? When do you say, you know what, their SAT's this, their respiratory rate is this, now I have to bag, right? And by the way, all we're really talking about is bagging to the point of pre-oxygenation where you can stop bagging, right? So where's the point you have to start bagging because you have no choice? What's your point?
I mean, I would say it's a tough question because I feel like what we've been trained to do is if they're breathing to the point that their oxygen saturation is steadily declining and it drops even below 95, then I usually reach for the bag. But that this article suggests otherwise, so.
Right, so let's say, I mean, what I usually quote is less than 4, although I acknowledge a lot of people say less than 6. And I say SATs less than 93, but again, there are people who say less than 90, but they're basically basing that based upon the oxygen load and saturation curve shifting with many of our patients. And again, you know, I'm just saying this during the denitrogenation period, right? So if you're trending down, I'm doing denitrogenation on you. I'm not bagging, and I'm trying to see if that is working. The high flow nasal cannula with a CPAP, maybe that will stop you from trending down at that moment, right?
Right.
And I think what Weingart goes over too is using the ventilator to oxygenate somebody. I mean, you have an automated bag valve mask that won't overcome the lower esophageal sphincter. You can take the mask of a bag valve mask, since it has a standard 30 millimeter fitting, and put it on any vent tubing. Set your ventilator to the rate of 12. Set your tidal volume or your pressure, whatever you're going to volume or pressure ventilate them. So you can set it to a sys control rate of 12 at 500 cc's. Put it on their face, and the ventilator will bag at a proper inspiratory rate, and you know, it won't be too fast, it won't be too slow, it won't be too forceful, you won't overcoat the lower esophageal sphincter, you can pre-oxygenate that person. And the best thing is too, is if they fail BiPAP or CPAP, keep the fancy hooded mask that's strapped on their face, and just take the vent circuit and plug it into there and set your ventilator on a sys control with a rate of 12 and 100% FiO2. You have an automatic bag valve mask next to any resus room. And
So you got me except for the 100% FiO2 part.
you can set that to anything you want.
Right.
It depends
Because
on why.
we're big believers post-Ross, based upon the most recent literature, that we're actually setting our FiO2 to more like 40% and
But if you're-
titrating down. Although I admit that I'm a little chicken and I'll start more like 60%. But that's better than years of starting everybody post-Ross at 100%.
But if you're already hypoxic and you're trying to pre-oxygenate
Yep.
them, you get 100% FiO2. But yeah,
That's the
absolutely.
place to start, sure.
Yeah, you can always titrate it. And it's really easy to titrate and accurately titrate it on
So
the
why do
ventilator.
more people do that?
I just don't think it's a regular practice. I mean, Weingart typically advertises that awesome. The guy's a brilliant man, and he says it often. Anytime his videos or any of his airway lectures or any of his memory devices and things like that, and he calls the laryngoscope a murder weapon. You call the bag valve mask a bag valve mask of death. I mean, there's a lot of risk in airway management, and if everybody starts doing the same thing, we're going to do it much better for
I
the
think
patients.
a lot of it, honestly, has to do with being able to be comfortable with managing your equipment.
Yeah.
And most people don't know how to use a vent. Most physicians
agree with that.
don't know how to use a vent. And so when you are not familiar with the equipment that you're dealing with and you rely solely on respiratory to manage your vent, then it becomes impossible for you to take a patient who's decompensating and throw them on the vent when you don't even know how to do it.
I also,
And when you ask respiratory to take care of that, they may not even feel comfortable doing what you're asking them to do because they don't even know that's an even novel idea to do.
Yeah.
I also think location of equipment matters as well. Like from the several hospitals that I was at in Chicago, a lot of times the vents are not in the ED.
God,
You
it's
have
a
to
huge-
call
yeah, that's a huge
respiratory to get them down there, and
Right.
how long does it take? It depends on the hospital, how well it's staffed. You know, the elevators, probably. So do you really have 20 minutes that it's going to take before you have to intubate that patient? Sometimes you do, and sometimes you don't. And so that might be part of the problem as well.
So creating a nasal cannula with a BVM with PEEP, you're effectively creating a CPAP phenomenon. So that's something that you can definitely do
Without bagging.
without bagging the patient. And that's something that, we always endorse as well. So if you don't have access to a vent and you rely solely on the patient's respiratory effort, now mind you, the patient does have to have a good respiratory effort. And if they can actually pull good tidal volume, you can actually create CPAP phenomenon just with that alone.
But if you're in a hospital by yourself, maybe Jim's idea is better, or Weingart's idea is better, just to, take the tube and hook them up to the vent with the CPAP mask. Because ultimately, if you do your BVM, you need somebody to hold that. And if you're
Sure.
by yourself, you can't hold it and do other things.
Right.
And also
Or
too,
have the
adding
seal.
airways in there too. I mean, 2 nasopharyngeal airways underneath a CPAP mask, you have a good, you displace that.
Right. No, I don't think it talks about it in this article, but we're big believers in
Multiple
double
airways.
nasopharyngeal airway, NP airways.
Yeah.
right?
And then listening to what was the other? It's not Wenger. What's the other guy's?
Levitan?
Levitan. I'm sorry, Dr. Levitan. I apologize. But listening to Dr. Levitan speak about it, his thing that is great is when his patients are desaturating, he sets them straight up in the air. He goes face to face with the patient. He grabs their jaw, pulls it forward, cranks up the nasal cannula, and he calls it O's up the nose. And just displacing the jaw forward, pulling that jaw forward, and then having a high flow nasal cannula on. He says he's resolved many hypoxic episodes just from doing those simple maneuvers.
Right. But of course, those have to be hypoxic episodes that have a cause that is reversible.
Absolutely.
Right? I mean, if you have hypoxic episodes due to multilobar pneumonia,
Yeah.
you're probably going to fail, right? If you have hypoxic episodes that are caused by acute decompensated heart failure, you can get over the hump and maybe succeed.
Yeah.
So it depends why they're hypoxic. right?
Absolutely.
Because the patient who is, I think, is multilobar pneumonia, who's septic, so a lot of these tricks, I mean, that patient I may be rushing a little bit more to intubate, especially if they're 90 years old with multilobar pneumonia and they're hypoxic. I feel much differently than the kid who can tolerate sats in the 80%, who has asthma, something potentially reversible, right? So it depends what your endpoint is.
Absolutely. You bring that up, that's a perfect thing because BiPAP and CPAP are temporary means and they're not to be used on somebody who doesn't have a reversible cause or hypoxia. I mean, if they're
Which pre-hospitally, we oftentimes don't know,
Yeah.
right? And it's really confusing, right? I mean, the best thing to figure out shortness of breath is still the history.
Yeah.
Because I say to paramedics, we get x-rays, lactic acids, we have time, we get a million things, and we still get a diagnosis wrong, right? So, and then if you read like Cecil's or some other books, a big cause of a compensated heart failure is sepsis and pneumonia, right? So that can drive you over the edge as well. So these things are complicated, right? And we all say, oh, the patient's multilobar pneumonia. It turns out to be heart failure. Right?
I think the bottom line, if you're going to make hard and fast one-liner rules, is if you're hypoxic despite supplemental oxygen, you need PEEP and you should be on CPAP or BiPAP.
Yeah.
One thing I will comment to, and something that some of our medics kind of allude to as well. We have this dogma, this rule of thumb, where if you're altered, you shouldn't get CPAP, and I agree to a certain extent. I believe that when you're pre-oxygenating the patient and you're in the room with the patient or you're in the back of the rig with the patient and you actually can see this patient, I think CPAP is acceptable. Okay, now that's given. And when the ED, when we're working, I wouldn't sit there and put a patient on CPAP who's altered and walk away. I'm in the room watching this patient, watching their airway status, making sure that they're not, vomiting into the actual, CPAP mask itself.
That's why it's clear.
Or up to the airway, exactly. So you're able to watch it. And the same way, you can actually pre-oxygenate a patient with CPAP if they're altered. That's perfectly reasonable to do. That being said, it's a temporary measure while you're inducing them, preparing for induction into RSI or intubation. And the same way, whenever they're altered, you're going to be going down that pathway. Now, it's not someone I would put on CPAP and just let them sit there for 30 minutes, but it's all about pre-oxygenation. So in the setting of pre-oxygenation, I believe it's the one scenario when someone is altered, you possibly can and they will benefit from CPAP.
Yeah. And I guess that you're talking about how altered they are. There's difference between somebody who's slightly altered versus somebody who can't even sit up and is just,
slumped over.
Yes.
Right.
Right. So the person that's slumped over, I'm starting to think about it. I'm thinking about intubating them.
Sure.
Right. And that's how many people just show up for EMS or show up at the door of the ER. They're slumped over, and you're thinking about intubating them.
Right.
That's lost airway. That's one of the three reasons why you intubate somebody.
Right. All right. So next is, what positioning and maneuvers should the patient receive during the apneic period?
So, that's me. Dr. Tan has kind of alluded to that already, just talking about some little tricks to use in order to get optimal positioning for success. So one of the things you mentioned was nasal trumpet or another kind of airway adjunct. So that was mentioned here as well. In terms of physical maneuvering of the head and neck, if there's a risk for spinal cord injury, same thing as BLS, the jaw thrust would be appropriate to open the airway. Otherwise, a head tilt, chin lift in order to try and stop the tongue from obstructing the airway. In terms of positioning, it does go back to what we said before as well, where we really don't want to lie anyone flat, if at all possible. I know in the pre-hospital setting, this can definitely be a big challenge, depending on what type of space you have with you. If someone's in the floor of a bathroom in between a toilet and a sink, you gotta, sometimes if they're still breathing, you gotta take a couple of minutes, you could bring them out. And in terms of positioning in general, one concept that they discuss here is something called ramping. So the goal, especially in a very large obese patient, is to try and get the patient in a position where their external auditory meatus is in line with your sternal notch, and we can post an image of that as well to see what that looks like. And it can be very dramatic, especially in the larger patient, because if you're not super skinny, you're going to have to lift these people up. The other thing they discussed is cricoid pressure, which is constantly being debated. And in this article, they did conclude that it may negatively affect apneic oxygenation, but no real studies have been done to date to confirm this. So, what they mentioned in particular is that cricoid pressure can actually laterally displace the trachea, so it's not whether or not it brings the cords more anterior into your view. It actually sometimes, and up to 90% of the times in one study, displaced laterally. So.
And then what about, they mentioned some stuff about paralytics, right?
Yes.
Oh, no, wait, that's
Yeah.
the next section.
That's the next
Yeah,
section.
I'm sorry, I apologize. Anything else with that section? That's it, right? All right, does the choice of paralytic agents affect pre-oxygenation? Are we back to Alex?
Yeah, so
Look at this, people still get
We
this wrong.
still-
This is 2012, and
Yeah.
he gave us the answer in 2012.
And we briefly discussed this this morning. We kind of had a side conversation about this morning. But again, this is it's a study of operative patients, and they looked at succinylcholine versus rocuronium. And essentially, we came to the fact that rocuronium is probably better. Rocuronium can provide a longer duration of safe apnea than succinylcholine. So the debate is still up, for some people, still back and forth. I think rocuronium is the better drug, especially if you dose it correctly.
But it wins on Cochrane because most of the studies on Cochrane just dosed it incorrectly.
Exactly. So it comes down to dosing. This specifically says that. It says when used at a dose greater than or equal to 1.2 milligrams per kilogram, rocuronium provides intubating conditions identical to those of succinylcholine.
And if you want to make the 1.2, 1.5, I think that's fine. There are many organizations out there that just say 1.2 milligram per kilogram. I think the point is that it's not lower than 1.2, right? Because we know our risk in like sucks of hyperkalemia occurs mostly from redosing of the sucks. And again, we always say this, we'll say it one more time, that you need higher doses of paralytics when your blood pressure is low, not lower doses. And all you're doing by giving lower doses is increasing the chance that you'll have to redose it and cause hyperkalemia. And that's the worst thing that can happen.
Yeah, at the institution where I'll be going, one of the critical care lectures that I've seen there was specifically talks about that. It says if you have a hypotensive patient, you half your sedative and you double your paralytic. I mean, your induction agent and your paralytic,
Right.
half for one, double the other, and then that kind of takes you down that path. So, and we talked about it this
I mean,
morning.
hopefully they're using good sedative.
Well, yeah. So,
The other thing I say is with the paralytic is you're not going to over paralyze someone.
Exactly.
They're either paralyzed or they're not.
Because, and I say that half jokingly, but ketamine is a sympathomimetic, so it basically increases your blood pressure and your heart rate. So if somebody's decompensating with hypotension, ketamine can certainly help that.
Yeah.
In general, although I guess, we acknowledge that if you have one catecholamine left in your body, ketamine can cause the same hypotension that every other drug causes, right?
Yeah, and then it's funny, what we were talking about, a good sedative, the sedative they were talking about was ketamine, and halving the dose instead of 1 to 2 milligrams per kilogram for induction, they just go to 1 milligram. That's their half, because they assume people are doing the 2 milligram, then you half that
Right.
to the 1. So you're saying you should theoretically still be getting good
Right.
sedative.
Again, it's probably more important people who are septic, who've been septic for a couple of days, who have no catecholamines left, rather than the patient who's acutely ill in front of you, right? They probably have more catecholamines left.
Two quick comments. When I give the medical control for induction for somebody who has a decent blood pressure, 2 milligrams per kilogram of ketamine and rocuronium. So if you're going to give somebody 150 milligrams of ketamine, give 150 milligrams of rocuronium, and you're still okay. And another comment on that too, is just to make the dosing simpler, but a separate comment to predict that peri-intubation hypotension. Sackles was telling us that we can use the shock index. So a simple way to do that is if your heart rate is higher than your systolic blood pressure, you are likely to become grossly hypotensive during the induction.
Right.
So give those
So it's a
push-ups
nice down and dirty
beforehand.
rule. If they
Absolutely.
say it again, if your heart rate's greater than your systolic blood pressure, it's bad.
Your shock index is positive, it's greater than 0.8 or essentially greater than 1, and that puts you in a very high risk, probably even in my own anecdotal experience, drops of blood pressure, you can almost count on it. And that's the type of person that you push 10 or 20 micrograms of push those epinephrine before you induce them, or push 100 micrograms of neosynephrine before you induce them.
Right.
And then based on the push dose pressors, if they're already tachycardic and hypotensive, I push more of the push dose neo versus.
And neo may be even more better. It may be better than epinephrine. We just say epi first usually because that was the first drug that was approved in our state for push dose pressors in New Jersey.
Sure.
So we just got used to doing that. Whereas many systems don't do this at all. Many hospitals don't do this at all.
Correct.
Many ERs don't do this at all. And the anesthesiologists laugh because they've been doing this for 30 years.
Yeah.
Right.
Yeah. I mean, we had a great induction at the hospital I work at just last night, where we had a emergency medicine pharmacist bedside preparing push dose phenylephrine, push dose epinephrine, improvised bedside drips on demand. We worked seamlessly and induction went great. It was,
And what did you get post-intubation sedation?
fentanyl.
You found
So, but yeah, it was
something that's pretty equivalent on your blood pressure,
Yeah. Yeah.
which
We
has some
balanced the
sedating
pressures.
effects and is good for pain. And that's another kind of Weingart-ism that pain first, sedation second. But you certainly can give ketamine drips, you certainly can give ketamine boluses, you certainly, and I don't think anything's wrong or terrible with Versed drips post-intubation or morphine drips post-intubation. I just think we have better choices. But I think they're better than doing nothing.
Yeah, and that's something we were talking about yesterday on a sidebar conversation, was if you give etomidate as your induction agent and 1 to 2 milligrams per kilogram of rocuronium, I think your patient is going to be paralyzed, paralyzed essentially for 30 to 60, maybe even 90 minutes, and your etomidate is only going to last 5 or 10 minutes. So it's so important to rebolus the sedative. You're not repeating etomidate. Etomidate's a one and done drug, but you need to give fentanyl, you need to give Versed, you need to give something, repeat ketamine. We're running into those problems now because ketamine's not readily available. We're doing our inductions now with etomidate because that's all we have.
Right.
But you're given a short-term sedative, a long-term paralytic. You must continue to, even if their blood pressure's on the low side, you manage the hypotension, post-intubation hypotension with your push-dose pressors, and you have to give that Versed, you have to give that fentanyl.
And we talked about this in the
You have
emergency
to
department
give it.
because maybe we're doing the wrong thing in the ER because we give the rocuronium and maybe the fentanyl before, and then we write an order for some sedation medication for the nurse, and if they're not giving it quick enough, which they may not be by the time they get out of the pixels and started, that means the rock is still on board and the patient is paralyzed yet not sedated enough,
Yeah.
right? So the ERs maybe not be doing a great job with this.
Yeah.
And this is something that I teach residents, interns, nonstop, is especially if you're going to in that pre-oxygenation phase, if you know it's going to take a while to get your sedative from the pharmacy, give a verbal order, do it right there at the bedside. If you have a computer, put your orders in, so that way as soon as you get that patient intubated, your meds are there and they're ready.
Right, this is why you have to ask whatever ER you're working, especially if you're working a lot, what medication do you have? Because if I order something, I want to know it's going to take 30 minutes to come up from pharmacy versus what you're going to get right away.
Yeah, or if you're going to, a great example of that is Precedex. I mean, I used Precedex for sedation all the time for post-intubation sedation at one of the hospitals. And some of the facilities I work now, they don't even do that in the ED. So if I ordered it thinking it's going to be great, I have my sedation order in there.
Yeah.
I don't find out for 20 minutes that you can't even get that drug.
And we love Precedex. I just wrote a Precedex protocol for our, fixed wing planes. The problem is it's expensive, right? So if your hospital may not have it based upon the cost, but one day when Precedex goes off patent, and I don't know when that will be, we're all going to be using Precedex and nothing else. Just a prediction.
And a good thing.
I love it. I think it's amazing.
Yeah, Precedex is awesome. But another thing that Weingart brings up is verbalize your airway plan right off the get before you've done anything to your patient. You're going to talk about your airway plan. We're going to induce with this medication. We're going to paralyze with this. We're going to post-intubation sedative with X, Y, and Z. And then, like I said, last night, we talked about this before we started, and the ED pharmacist had the fentanyl already on the pole before we did the induction.
Yeah, and I would say even more important than that is the conversation of what's going to happen when you can't get
Pulled
the
out,
tube,
it's there.
right? Because the moment you can't get the tube, what will happen? Instincts will take over, and people will grab the bag of death and just start squeezing like crazy. When that may not be the right thing, and maybe it depends upon the saturation. If somebody's not desatting at that moment, but just can't get the tube, maybe go back to passive oxygenation and more denitrogenation.
Or you have the ventilator already set up next to you. Leave the mask on their face,
Yeah.
plug the vent circuit into the mask, do a jaw thrust,
turn event to start, the same settings that you were going to do if the tube was in their head.
So your point is, don't throw away the CPAP mask
Keep
after
it-
you
yeah.
take it off the patient,
Yeah.
right? You could just put it back on the patient, so you have to have that conversation. Who's gonna do what when we can't intubate, right? But we don't have those conversations, and the quick thing is you just grab and you start bagging with no oxygen.
Right.
Right, and that's why people vomit.
Sure.
All right, where are we?
That's pretty much it.
So we talked about that, risk stratification, inclusion. Anything else with this? Did we miss anything? No, all right. So very simple journal club, it's 2:30. Where are we going this week for anybody? We are at the Warped Tour on Saturday. I'm sure we're at the a Yankee game or two next week.
Next week.
And where are we Sunday?
Sunday, I think we're just pre-hospital, and then we have the state police, but.
Oh, Friday. All right, sounds good. Thanks for joining us. If, remember, get on our email list. We're going back to regular Journal Club articles next Wednesday. We're back here at Monarch, Maine on Wednesday. And that's it. Thanks for joining us.